All right, welcome. Go ahead, take a seat. We're about to run through a simulation of a consultant-level surgical viva, pretty much exactly like you'd see in the Saudi Commission for Health Specialties exam. And today's topic? Oh, it's a classic. One you are guaranteed to face: the thyroid nodule. We're going to test your structure, your knowledge, and, most importantly, your clinical judgment under a bit of pressure. So, let's begin.
Right now, I want you to forget everything else. For the next 10 minutes, you are the surgical candidate, and I'm your examiner. Every question I throw at you, every little piece of information I give back, it's all designed to see how you think on your feet. This isn't just about spitting back facts from a textbook. It's about showing me you have the judgment of a consultant surgeon. Your exam starts now.
So here's our game plan for this case. We'll kick off with the initial scenario, walk through a proper history and examination, put together the diagnostic puzzle, and then you'll have to commit to a surgical plan. And just when you think you're comfortable, we're going to hit you with a complication. How you handle each one of these steps is what makes the difference between a pass and a fail. Let's get into it.
Okay, I'm about to give you the opening scenario. Listen very carefully because every single word matters. How you first respond really sets the tone for the entire viva. You ready?
A 29-year-old woman was seen for a sore throat and, during that exam, was noted to have a mass in the left side of her neck. So this is an incidental finding, which, is a very, very common presentation. Your clock has started.
Okay, so first things first, history and physical exam. This is the foundation for your entire plan. If you're sloppy here, or if your exam isn't focused, you're going to go down the wrong path fast. What we're looking for as examiners is a systematic, repeatable, and really thorough approach.
Right then, candidate, how would you approach this patient?
Okay, I'd start by taking a really thorough and structured history. First up, I'm going to focus on the lump itself. How long has it been there? Has it been getting bigger? Is there any pain? Next, I'm going to specifically ask about pressure symptoms. Any trouble swallowing, any pain with swallowing, or any hoarseness in her voice, which could be a red flag for local invasion. Then I'll screen for systemic symptoms of thyroid issues, both hyperthyroidism, things like sweating or heart palpitations, and hypothyroidism, like constipation or feeling tired all the time. And absolutely crucially, I'll ask about any family history of thyroid cancer or other endocrine stuff like MNN syndromes, and of course, any history of radiation to the neck.
Very good. The patient tells you she's noticed a swelling for about a year. She denies any pressure symptoms, and there's no other relevant personal or family history to speak of.
What will you do next?
I'd move on to a focused physical examination. After getting consent and making sure she's comfortable, I'll start with a general look and check her vitals. Then for the neck itself, I'm going to inspect and then palpate that swelling, really systematically assessing it for site, size, shape, surface, and what it feels like. Is it soft, firm, or rock hard? Then I'll ask her to take a sip of water and swallow to see if the mass moves up. That's the classic sign of a thyroid lesion. Finally, I'm going to carefully feel for any swollen lymph nodes in her neck, really paying attention to the central and lateral compartments. Right now, my top differential is a thyroid nodule, but I'm keeping things like a lymph node or maybe a congenital cyst in the back of my mind. The exam should help me narrow it down.
All right, you've gathered your initial clinical data. Now it's time for the workup. This part is all about using investigations logically and cost-effectively to really sharpen your differential diagnosis and build the case for your final plan. Every single test needs a solid reason behind it.
On examination, you confirm there's a firm swelling on the left side of the neck and it moves up when she swallows. You don't feel any suspicious lymph nodes. So how are you going to manage this patient?
My management from here will kick off with some initial investigations to really pin down what we're looking at. I'll order blood tests, starting with a thyroid-stimulating hormone, or TSH level. That's the single most important blood test here. If the TSH comes back abnormal, then I'll add on a free T3 and T4. I'll also get a baseline CBC, electrolytes, and coags, just thinking ahead in case we're heading to the OR. But the most crucial next step is imaging. I'm going to request a dedicated ultrasound of the neck. It's really the best tool we have for looking at thyroid nodules and checking for any suspicious features or any surprises on the other side.
Excellent. Okay, the TSH comes back normal. The ultrasound shows a 1.5 centimeter solid nodule on the right side and a smaller half-centimeter nodule on the left. So you proceed with an ultrasound-guided fine needle aspiration of both. And now here are your results. The right nodule comes back as follicular neoplasm. The left nodule sample is inadequate for diagnosis even after you did it a second time. Let's just pause and think about this.
A follicular neoplasm is an indeterminate result. It's a gray area. We can't tell if it's benign or cancer on cytology alone, and it carries a pretty significant 15 to 30% risk of malignancy. And that inadequate sample on the left, especially after 2 tries, that's also a bit of a red flag.
Okay, this is the moment of truth. You've got all the data, you have a high-risk, indeterminate lesion on one side and a non-diagnostic, suspicious situation on the other. You have to pull all this together and commit to a definitive plan. And let me tell you, your justification for that plan is just as important as the plan itself.
So based on these results, what are you going to do next?
Based on these findings, I'm going to counsel the patient for surgery. My recommended operation is a total thyroidectomy. Now look, a diagnostic right hemithyroidectomy is definitely an option, but given that she has disease on both sides and that left nodule is persistently non-diagnostic, a total thyroidectomy is just the more definitive and, I think, better approach. It deals with the cancer risk on the right, and it removes the suspicious nodule on the left, which avoids the very real possibility of needing a second operation later. Of course, my pre-op counseling is going to cover all the risks: bleeding, infection, the scar, and specifically the big ones: the risk of injury to the recurrent laryngeal nerves causing hoarseness, and hypoparathyroidism, which can cause low calcium.
You've decided on a total thyroidectomy. It's a fine choice. So tell me, you're in the OR. Which lobe will you start with, and why?
I'll start with the right lobe. The principle here is you always address the side with the higher suspicion of cancer first. The right lobe has that larger 1.5 centimeter follicular neoplasm, and that's the main reason we're doing this operation. My key steps would be the standard approach: a coach or incision, raise the subplasma flaps, separate the strap muscles, mobilize the lobe, but the really critical part is the careful dissection of the superior pole to protect the external branch of the superior laryngeal nerve, and then most importantly, identifying and preserving the right recurrent laryngeal nerve and all the parathyroid glands before I finish the dissection.
Your plan is solid. The justification is sound. But you know, surgery is unpredictable. A truly competent surgeon isn't just someone who can operate well when everything goes right. It's someone who knows what to do when things go wrong. This next question is designed to test your judgment in a crisis. You're proceeding with the right hemithyroidectomy. During the dissection down near the ligament of Berry, you believe you have just injured the right recurrent laryngeal nerve. What are you going to do?
Okay, let's just pause here. This is a critical pass or fail moment. Your immediate response to a disaster like this reveals everything about your fundamental approach to patient safety. If you panic or hesitate, you fail. A calm, structured, safety-first response is an immediate pass. So the question is, what do you say? The very first thing I will do is stop. I'll complete the planned right hemithyroidectomy since the gland is already mostly mobilized, but I will absolutely not proceed to the other side. My number one priority now is to avoid a bilateral vocal cord palsy, which is a catastrophic, airway-threatening emergency. I will clearly document the injury. I'll request an immediate intraoperative consult from my ENT colleagues to assess the nerve. And post-op, I will explain exactly what happened to the patient and her family. The plan for that left nodule changes completely. Surgery on that side is now deferred indefinitely. It now becomes a case for active surveillance with ultrasounds. Patient safety is the absolute priority here, period.
And scene. You've navigated the crisis, so let's debrief this whole thing. The viva is really a performance. By showing a clear, logical, and safe approach, you've just demonstrated to the examiners that you have the qualities of a consultant. So let's break down the core principles that get you a pass.
So, what did we just learn? First, always have a structure. Your approach from history all the way to the final plan needs to be systematic and predictable. Second, justify every major decision. Don't just say total thyroidectomy. Explain why that's the best choice for this specific patient. Third, and this is the big one, patient safety is king. Honestly, showing you know when not to operate is often more impressive than showing you know how to. And finally, when a crisis hits, remember the mantra: stop, take a breath, think clearly, and then act methodically. That is the hallmark of a safe surgeon.
You have successfully passed this station, but in the real exam, and in real life, the next challenge is always just waiting around the corner. You've mastered the thyroid nodule today. The question that remains is, what case are you going to face next, and will you be ready?